deliveries. So if there are questions regarding the position of the anal fissure, you can say that the posterior midline 90% of the people most commonly, but in a female which are due to the vaginal deliveries to the anterior midline. Almost all the rest located in the anterior midline. The acute fissure is in a mare, a crack in anoderm. The distal sagittal leg, a proximal hypertrophied anal papilla, fibrotic edges, and exposed internal sphincter fibers are feature of chronexity. So here we are talking about the most common complaints are clinical features of the anal fissure. So most commonly position is basically a posterior midline, and acute fissure shows a mere crack. And another features related to anal fissures are the distal sagittal tag, a proximal hypertrophy anal papilla, fibrotic edges, and exposed internal sphincter fibers are feature of chronexity. If a patient comes to you with a complaint of pain during a defecation, it has some fibrotic area, because if there is an unhealed ulcer which starts to healing, which covers this healing process, it shows the fibrotic changes, fibrotic edges. Internal sphincters, if the internal sphincters are exposed, it shows the chronicity. So this is all about chronic anal fissure. The initiating factor is the trauma. So what are the etiology and pathogenesis? The initiating factor is the trauma, typically overstretching of the notum by large hard tissue. The most commonly the patient comes with a complaint of constipation. It can cause the overstretching of the notum. So that's what causes the fissure. The proposed explanation for the posterior midline predominance is a lack of tissue support and a maximal stretching of the side. Failure to heal the secondary poor perfusion of notum in the posterior midline. The posterior midline ischemia is a result of arterial anatomy and internal anal sphincter hypertonicity. So due to the why it is a common in the posterior area, because of the arterial anatomy and internal anal sphincter hypertonicity, because the posterior area is the most constricted area of the internal sphincter, so that's why it can cause posterior. And there is a poor perfusion, there is a less blood supply, there is a less perfusion area over the posterior, so that's why it becomes that. So what are the management site? If you are talking about treatment, there is a warm bath. So first of all, start with the conservative management. And conservative management, we have to go some modifications, like a vegetable diet, like a high fiber diet. We ask patient to use a less amount of oiled food, which decreases the constipation. And we ask patient to take a stool softeners, fiber supplements, like spagol husk and some fibrotic diets, which causes to soften the stool. And we ask patient to take a sit bath in a warm water, normal warm water. In the 50% of acute anal fissure heal within the 3 weeks. The only within the 1 month, a patient can satisfy with this management, with this conservative management. 50% of acute anal fissures almost. So the recurrence is a common in the range of 30 to 70%. It can be reduced to 50 to 80% by maintaining a high fiber diet. So recurrence is the most common because the situation is the same, area is the same. There is a hypertonicity of the internal anal sphincters, so it can cause acute fissure topical application. So nitric oxide, after the modification of the diet, after the conservative management, we also give some conservative, we also extend the conservative management with some medications, like a topical applications like a nitric oxide, 2%, 0.2% nitric oxide, 0.2% nitric oxide. Help identify a chemical messenger. Nitric oxide basically is a chemical messenger, which is a intrinsic non-allergenic or and non-cholinergic pathway mediating relation. It relaxes the internal anal sphincter. Topical application of nitroglycerin nitric oxide causes a transient lowering of resting anal pressure and increase the abnormal blood flow. 92% of healing rate with the 2 weeks for acute fissures. Treated with the application of 0.2% glycine nitrate ointment (TDS). So there are the 92% chances within the 2 weeks, just 2 weeks. If we are just modifying the diet and giving the six bath, patient has the chances of recovering 32. Patient has recovering chances 50% almost, and within the 3 weeks. But when you're applying the GT and cheme glyceride nitrate ointment, it causes the another ointment, which is a calcium channel blocker. It's a 2% deltasium. Deltasium is 0.3% nifedipine. These are the calcium channel blockers. It also relaxes the internal sphincter. It also relaxes the internal sphincter, and it heals the 65 to 95% fissures. Most common side effects are the headache, flushing, and symptomatic hypotension. So all are the management of the acute fissure, in which it needs to relax the internal sphincters either by the 0.2% chitin cream or the 2% calcium deltasium, which heals the 65-95%. Most common side effects: headache, flushing, and symptomatic hypotension. Now comes to the chronic fissures. The topical nitroglycerin at 8 weeks, at least 2 months, healing was observed in 68% of GTN. In a chronic, if we are talking about the chronic fissure, we can give a trial to the chronic fissures. So 8 weeks healing was observed in 68% of GTN. The botulinum toxin has been injected into external and internal sphincters, and with a short-term follow-up, healing rates of 80% have been achieved. So botulinum toxin is also a management, but these are the management for the chronic fissures. So if you are talking about the glycerin, topical nitroglycerin can be applied to the acute and can be applied to chronic. Botulinum toxin is just for the chronic fissure, not for the acute fissure. So after are unlikely to heal with the warm baths and high fiber diet. So high fiber diet and warm waters are not. I have discussed earlier the how would you define the chronic fissure. Chronic fissure you can define by the fibrotic edges, by the segmental tag, by the hypertrophied papillas. So these are the clinical symptoms you can justify that it's a chronic fissure. So chronic fissure cannot be dealt with the simple warm water and warm sitz bath or high fiber diet. But you can give them the nitroglycerin, you can give the trial of nitroglycerin, 0.2% nitroglycerin. You can give them, but you can give them the botulinum toxin. It can also relax internal sphincters. So after applying the all topical enhancement and all, and if there's no treatment, then you can go for the procedure, a surgical procedure which is called internal sphincterotomy, which is also it basically what happened in this in process. It is a lateral internal sphincterotomy achieves, which covers the 95% of the severed peaks. Internal sphincterotomy, you're going to cut the internal fibers which decrease the tone, which decrease the anal tone, and it helps to in a healing process. Another process is the